So our first lecture for Anatomy and Physiology 2 is the endocrine system, chapter 16 in our textbook. And so we'll get started with this chapter. The endocrine system is a system that releases hormones that affect numerous activities throughout the body. Now, you have a differentiation between endocrine glands and exocrine glands. Exocrine glands are ducted glands. Endocrine glands dump their product directly into the bloodstream. This will become important later because we'll see that the glands dump their product into the bloodstream and there has to be a way for them to get to their appropriate gland, organ, muscle, whatever it is. Now, the hypothalamus is what controls the endocrine system. It does release hormones. It makes some hormones and stores some in the posterior pituitary, but it controls both the anterior and posterior pituitary, and we'll be getting a little more detail on that control system in just a little bit here. This just shows an overview of the different endocrine glands. Now, as I said, hormones are made in the endocrine system, and these are long-distance messengers, which means they travel throughout the whole body. You have other chemicals, and depending on the textbook, sometimes they're classified as part of the endocrine system, and sometimes they're not, or classified underneath hormones. But there are other chemicals, and the textbook that we use, Marieb, does not define these as part of the endocrine system, but they are similar. They're called autocrines and paracrines. Now, auto means self, so autocrine is a chemical that exerts an effect on the same cell. An example I have here is prostaglandins released by smooth muscle affect those cells that release those prostaglandins, which are hormone-like substances. Paracrines, para means around, next to, or near, and this is a chemical that affects the cells next to it, right? So right around it. Somatostatin released by pancreatic cells affects other insulin-releasing pancreatic cells near or next to it. And so that's another example there. Two main classes of hormones, and you'll see in some of the slides here, we're going to kind of be classifying and categorizing a number of things, but the two main classes are going to be your amino acid-based hormones, which has amino acid derivatives, peptides, and proteins, and then you have steroids is another class, and all steroid hormones are made from cholesterol, and we'll talk more about those later. So if hormones get dumped directly into the blood, how do they get to their destination? Well, we have what's called target cells. Target cells are tissues that have receptors for that specific hormone. So the hormone gets dumped into the blood, it circulates around. When it hits a target tissue, and there might be more than one, but when it hits a target tissue that has receptors that are specific for that hormone binds to those receptors, and then you get the activity of that hormone. This slide you can read from your PowerPoint notes. It just gives you the general actions of hormones on target cells. We'll get into more specifics of each hormone and what each hormone does. Now, another classification we have here are water-soluble hormones and lipid-soluble hormones. Your water-soluble hormones are going to be all of the amino acid-based hormones except for thyroid hormone, which is amino acid-based, but it's not water-soluble. And some other things we need to know about water-soluble hormones is they don't pass through the cell membrane. So the receptors for these specific hormones are going to be on the cell membrane. So the plasma cell membrane receptors is the location where these hormones bind. Another thing that's important to understand about water-soluble hormones is that they use second messenger systems. And the two second messenger systems that we talk about, or at least we reference, you don't have to know the details of, but is the PIP mechanism and then the CAMP, which is the cyclic AMP mechanism. Lipid-soluble hormones are going to be all of your steroid hormones and thyroid hormones. And these do pass through the cell membrane, so the receptors for these are going to be inside the cell. They are intracellular receptors. Another difference is they have what's called direct gene activation. So they directly activate genes and give a more direct effect, whereas using those second messengers for the water-soluble hormones is kind of a cascade of effects to get to the desired result. This shows a cyclic AMP second messenger system. You don't have to know any of the details on this, but what I want you to see on this is that it is a step-by-step process. So in other words, the binding of the hormone to that extracellular receptor is going to cause a reaction that causes another reaction that eventually gets to our end desired reaction. So it's kind of like tipping dominoes, and eventually you get to the end. This shows the PIP mechanism, which is a different second messenger system, but again, very similar in it's a step-by-step process to get to the target response that we wanted initially from that hormone. And this slide illustrates the steroid hormones. You can see it moving through the cell membrane on the picture, binding to an intracellular receptor, and then causing that direct gene activation. Now, what is target cell specificity and why is it important? Well, target cell specificity means that certain target cells will have the receptors for that hormone. If they do not have a receptor for that hormone does not affect those tissues. So we have something like ACTH. We'll talk about this later, but it's adrenocorticotropic hormone. This one binds to receptors only found on the adrenal cortex. So it doesn't bind anywhere else in the body. You have other hormones that are a little more widespread in the number of tissues they affect, something like one of your thyroid hormones called thyroxine. There are receptors found on nearly all the cells of the body, which means that thyroxine will bind to all sorts of different tissues or most of the tissues throughout the body. So what determines the amount of activation? Well, there's three factors. Blood levels of hormones, so the more hormone you have, the more activity of that hormone, that makes sense. The more receptors you have on the target cell, the more binding you're going to get of the hormone, which means more activity as well. So less receptors, less activity. And then affinity of binding, this is the ability to bind tightly to, so bind better. The affinity, if that increases, so the receptor binds better to the hormone, then you're going to get a more effect from that hormone as well. Now your body has the ability to do this really interesting thing. If the hormone levels drop a little bit lower, what your body can do is it can build more receptors on that target cell, and that means you're going to, even with less hormone, you're going to get more binding because you got more receptors, and so it'll upregulate the effect and bring it back to homeostasis, back to normal. The opposite's also true. If the hormone levels rise a little too high, your body can break down receptors on a target cell, so you get less activity, so you don't move out of balance. Now, of course, when it moves too high or too low, that's when you have your homeostatic imbalances where you wind up with disease processes and endocrine dysfunctions. Blood levels of hormones are controlled by negative feedback systems. Well, what does this mean? If you remember from Anatomy 1, the negative feedback system essentially is this. Let's say the blood levels of the hormone rise, there'll be a shutoff mechanism, right? Once we get back to homeostasis. Okay, if it gets too high and you're lowering the blood levels of that hormone, once it gets back to normal, again, you shut it off through negative feedback, and we end up with homeostasis. Not all hormones use negative feedback, but the majority of hormones do. And we're going to go through all the hormones so you'll see which ones use what. Now, there's something else important. There's 3 different mechanisms of release. So what causes the hormone to be released or not released? Well, humoral stimuli, humor means fluid. Humoral stimuli is a shift, some kind of shift in fluid. And we're going to go through examples of these in a moment. Neural stimuli is going to be a neurological stimulus, so a nerve impulse. And hormonal stimuli is going to be a hormone, causing the release of another hormone or the inhibition of that hormone. So humoral stimuli, we said, is a shift in fluid. So if we have a shift in the concentration of the fluid, in this case we're going to be always talking about blood when it comes to hormones, right? Because that's where they get dumped into. Calcium levels, if they drop, here's a good example. If they drop, it stimulates a release of a hormone that's going to cause a rise in calcium. So parathyroid hormone, we'll learn later, is the hormone that causes the rise in calcium. Once calcium gets back to normal, parathyroid hormone shuts off. But the stimulus was a humoral stimuli. It was a shift in calcium. Another good example that I don't have listed here is insulin, and we'll talk more about insulin later. But if we have a rise in blood sugar, so again, the fluid is shifting, right? The sugar, the glucose is getting too high, our body will release insulin. Insulin puts the sugar back into the cells, and then when the blood sugar is normal, we shut off the production of insulin. That's another example of a humoral stimuli. And this slide gives you a visual of that humoral stimuli, talking about the calcium levels and parathyroid hormone. Now, a neural stimuli is what it sounds like. It's going to be a nerve impulse, and that's going to trigger the release of hormones. So an example of this would be the adrenal medulla produces these hormones called catecholamines, like epinephrine, norepinephrine. So epinephrine is adrenaline. So to give you an example, you'll send a nerve impulse to the adrenal medulla, which will cause a release in epinephrine. And then here's the visual of the neural stimuli. You can see the nerve going to the adrenal medulla and the subsequent release of the hormones. The third, last but not least here, we have hormonal stimuli. This is actually a very common one. Hormonal stimuli simply means this. One hormone gets released and it binds to another endocrine gland that causes the release of a hormone. And so one great example of this is the hypothalamus. It makes hormones, and those hormones will bind to the anterior pituitary and cause a release of another hormone. So then we're going to talk more about their relationship in just a little bit, but this gives you a good example. The pituitary gland as well will release these hormones that will affect other glands. So for instance, it'll make something called thyroid stimulating hormone. Well, that hormone released from the anterior pituitary is going to go to the thyroid. It's going to cause the thyroid to make thyroid hormones. So that's another example of the stimulus, a hormone being the stimulus for the release of another hormone. And here you can see our visual of both the hypothalamus affecting the anterior pituitary with a hormonal stimulus, and then the anterior pituitary affecting other endocrine glands as well. Now, the endocrine system is a good manager of body functions, but the nervous system does control everything. It does modify stimulus of endocrine glands and can override the endocrine controls. One example, a really good example of this, is under stress. The hypothalamus will activate the sympathetic nervous system, and then, of course, you're going to get your sympathetic nervous system effects, right? Your fight or flight responses. So we said hormones get released from the endocrine glands and get dumped directly into the bloodstream. How do they circulate? Well, steroid-based hormones and thyroid hormones are usually attached to plasma proteins. Not all of them, a high percentage. And then all the other hormones generally circulate without carriers. Now, what about the concentration of a hormone? What causes the hormone to increase or decrease in the bloodstream? Well, there are two things. One would be how fast we're releasing it, right? And the second would be how fast we're getting rid of it. So the speed that we inactivate and remove that hormone from the body. That's going to determine the concentration of that hormone in the bloodstream at any given time. Well, how do we remove hormones from the blood? Well, we have three mechanisms. One would be degrading enzymes, and we see this in Anatomy 1, where we see an example with a neurotransmitter called acetylcholine. It has an enzyme called acetylcholinesterase that breaks it down, so we can remove it from the neuromuscular junction. Kidneys are a second way that we remove hormones from the blood, and the liver has some degrading enzymes as well, or some enzyme systems in there that will break down hormones as well. Now, the term half-life is kind of important to understand as well. It's a chemistry term, and when we apply it to hormones, it's no different. It's simply the amount of time required for the hormone's blood level to decrease by half. Now, sometimes this is tricky because let's say we have 3 milligrams of melatonin. Well, I think the half-life for melatonin is somewhere around 45 minutes. So in 45 minutes, that's going to be 1.5. And you say, well, okay, well, in another 45 minutes, it's gone. That's not how half-life works. So in 45 minutes, it goes from 3 milligrams to 1.5. In another 45 minutes, it goes from 1.5 to 0.75. And in another 45 minutes, it goes from 0.75 to I believe that's 375. I might get my numbers right, but so it's going to continue to decrease by half each time. So that's your half-life. So in our last slide, setting the introduction for the endocrine system, we have the three types of hormone interaction. The first is called permissiveness. Now, in permissiveness, we have one hormone cannot do its job or exert its effects without another hormone being present. And a great example of this is the thyroid hormone and the reproductive system. So the reproductive system cannot do its job properly without thyroid hormone. Now, the arrow doesn't go both ways. The thyroid hormone doesn't need the reproductive hormones to work, but the reproductive hormones do need the thyroid hormone to be present in proper amounts for it to for them to exert their effects. The second one is called synergism. Okay, and you can think of the word synergy. This is where more than one hormone produces the same effect on a target cell. Now, it doesn't mean they produce all the same effects, but the two hormones, or whatever we're comparing, this is always comparative. These are three comparative terms. So in other words, you can't just say a hormone's permissive. There's no such thing as that. It's permissive in relationship to another hormone, or it's synergistic in relation to another hormone. Same thing with antagonism, okay? So again, these are comparative terms. Now, let's look at our example. Glucagon and epinephrine both do the same thing in regards to blood sugar. Okay, we can actually add cortisol and growth hormone as well. Okay, we can add growth hormone and cortisol to the list of glucagon and epinephrine because all four of those will increase blood sugar. Okay, now epinephrine does other things as well. Growth hormone does other things as well. Cortisol does other things as well. But in regards to the release of blood sugar, all four of those are synergistic or have a synergistic relationship. Antagonism is where one hormone does the opposite effect of another. A great example of this is insulin and glucagon. Insulin will lower blood sugar, glucagon will raise blood sugar, so they have an antagonistic relationship in regards to blood sugar. Insulin does have other effects, but in regards to blood sugar, these are antagonistic. We can even give another example of this. We'll say calcitonin. It actually lowers blood calcium, and we said before parathyroid hormone raises blood calcium. Those two have an antagonistic relationship between each other. So the pituitary gland, also known as the hypophysis, has two parts to it. Now, hypo means below, right? And physis means to grow, and so hypophysis actually translates as to grow under. And that's a good visualization because it looks like a little fruit that's growing underneath the hypothalamus. So if you remember from Anatomy 201, you should have looked at the brain. You can see the stalk called the infundibulum that connects the pituitary gland to the hypothalamus. Now, the two parts of the pituitary gland, the first is the neurohypophysis, and the second is the adenohypophysis. The neurohypophysis is the posterior lobe of the pituitary gland. It is neurological tissue. And this one, the neurohypophysis, is going to receive, store, and release / secrete, they're the same thing, hormones from the hypothalamus. Okay? The adenohypophysis is the anterior lobe. The A gives it away, right? So the A and A, anterior adenohypophysis. And that one's glandular tissue. This one's going to make its own hormones. So it's actually going to synthesize and secrete / release its hormones. The reason I'm specifying this, sometimes people think secrete and release are different things. At least in this case, we're talking about the same thing, just different wording has been used on the slide. So, adenohypophysis, glandular, anterior portion, makes its own hormones and releases them. Neurohypophysis is neurological tissue. It does not make hormones. This is super important. The posterior pituitary does not make hormones, but it is going to receive some from the hypothalamus. It's going to store them, and it's going to release them when it's told to. So as we said, the posterior pituitary is neural tissue, so its connection to the hypothalamus is going to be a neural connection. It's going to be via the hypothalamic hypophyseal tract. Now, the hypothalamus makes lots of hormones, but it's going to make two specific hormones that it's going to store in the posterior pituitary. Those two hormones are oxytocin and ADH, which is antidiuretic hormone, also known as vasopressin. Now, as we said in the last slide, the posterior pituitary does not make its own hormones, but it does store these two hormones. And then when it is neurologically stimulated by the hypothalamus, which is how the posterior pituitary is controlled neurologically by the hypothalamus, then it releases those hormones. This slide gives you a visualization of the neurons coming down into the posterior pituitary. Okay, so we're going to talk about those two hormones. First, we'll talk about oxytocin. Oxytocin is a stimulant of uterine contraction, and it doesn't use a negative feedback. It's a positive feedback mechanism. And what's going to happen is it's going to cause an increase in intensity and frequency of uterine contractions that ends in the birthing process. And now a positive feedback mechanism, if you can remember from Anatomy and Physiology 1, it's different than negative feedback. Negative feedback is kind of like your thermostat, right? Once the temperature gets to a certain degree that the thermostat is set to, then it shuts off by negative feedback. Well, The positive feedback mechanism is essentially we have a goal and we're going to produce something that causes more of that to be produced, that causes more, and then the process is complete, and then it's less as we remove, in this case, the hormone from the blood. So the oxytocin uses this positive feedback mechanism. Now, a couple of other effects of oxytocin. It triggers milk ejection, which is called the letdown reflex. So it doesn't cause production of milk. Okay, we're going to see prolactin does that, but it is important for the milk ejection, so it is important for breastfeeding. Another role, it plays a role in sexual arousal and orgasm in males and females, and then it can act as well as a neurotransmitter in the brain. ADH, antidiuretic hormone, also known as vasopressin, this is going to anti-diurese. So first, let's figure out what diuresis is if we're not familiar with this term. Diuresis means the formation of urine. It does not mean to urinate. It means the formation of the urine. So if I block the formation of urine, right, what do? I retain more water in the system. Why would we want to do that? Well, if you were dehydrating, right? So this helps avoid dehydration because it's preventing the formation of the urine, okay? Now, a couple of other things I want to talk about with this. When we talk about the solutes here on this slide, we're talking about the concentration of blood. Solutes are the dissolved substances in a solution, the solution being the blood. So if the solute concentration is high, okay, if the solute concentration is high, we're going to want to put more water into the blood. Okay, so what do? In that case, we release ADH so that we prevent diuresis, the loss of urine, right? Because we produce the urine, we're going to micturate it, which micturition means to urinate. If the solutes are low, right, we want to get rid of some water from the blood, and so ADH gets blocked in that case, so that you will diurese, and then you will lose that water, which is what you want if the solutes are too low. Another little bullet point here, alcohol inhibits ADH release, and this is how it causes that copious urine output. Right, lots of urine output because what alcohol is doing is it's blocking the thing that blocks diuresis. And if you block the thing that blocks diuresis, you cause diuresis, which is the formation of urine. Now I'm going to mention this right now because we're getting to our first homeostatic imbalance. But in all of the chapters in Anatomy 202, make sure you know all of the disorders, diseases, homeostatic imbalances, and dysfunctions. They are super important. And honestly, they are heavily tested. Diabetes insipidus. Now, a lot of people think, that there's diabetes type 1 and 2, and maybe insipidus is one of these. This is a very different. So diabetes mellitus has a type 1 and 2 we'll talk about later in the chapter. Those are both a type of diabetes mellitus. Diabetes insipidus has nothing to do with your blood sugar. So what is it? It's an ADH deficiency due to either damage to the hypothalamus or the posterior pituitary. Of course, it's going to cause a lot of urine output because, again, low ADH. ADH is what blocks that diuresis, right? So it's going to prevent the formation of urine. If we're not preventing the formation of urine, we're forming lots and lots of urine, which is also going to lead to intense thirst and, the need to stay hydrated. The most common cause, I believe, still of this would be head trauma, okay? Now, there's another imbalance called SIADH, which is syndrome of inappropriate ADH secretion. And this is a hypersecretion, so too much ADH. It can occur from trauma, it can occur from cancer, it can occur after neurosurgery. And if ADH prevents diuresis and we're making too much of it, then that means we're retaining fluid too much, right? There's too much fluid. We're not getting rid of enough fluid. So it can cause headache, disorientation. It can mess with some other things as well, like blood pressure. So that's SIADH. The anterior pituitary has a vascular connection to the hypothalamus, and there's this hypophyseal portal system that's going to carry releasing and inhibiting hormones made by the hypothalamus to the anterior pituitary. Here's the visualization of that system. The anterior pituitary is going to make 6 specific hormones: growth hormone, thyroid-stimulating hormone, adrenocorticotropic hormone, follicle-stimulating hormone, luteinizing hormone, and prolactin. We're going to go through each of these, their functions, dysfunctions if there's homeostatic imbalances, and we'll go from there. Now, the hypothalamus controls the anterior pituitary or the adenohypophysis hormonally. Remember we talked about different modes of release? Well, a hormone from the hypothalamus is going to cause a hormone from the anterior pituitary to be made and secreted. So, and this, I like when names are easy like this. So releasing hormones are going to stimulate the synthesis and release of other hormones, and inhibiting hormones are going to shut off the synthesis and release of hormones. So when we see something like growth hormone releasing hormone, it's going to cause the release of growth hormone. If we see growth hormone inhibiting hormone, that's going to cause the inhibition of the production and release of growth hormone. So we'll start off with growth hormone first, abbreviated as GH, or also known as somatotropin. Now when you see HGH, human growth hormone, of course that's the same thing, but it's usually used to reference the synthetically made human growth hormone. So with actions of growth hormone, there are direct and indirect actions. Direct actions on metabolism are things like increasing levels of fatty acid, using those fatty acids for fuel, also protein synthesis. This is an anabolic hormone, by the way. Whenever you hear that something increases protein synthesis, that's anabolic. Okay. Another thing that it does, it decreases the rate of glucose uptake, conserving glucose. It has an anti-insulin effect. What happens is it causes glycogen breakdown and glucose release into the blood. Right, so what does that do? Well, it causes a rise in blood sugar. That's the opposite of insulin, which is to lower blood sugar. It's actually an antagonistic relationship. We talked about those relationships earlier. Well, what about the indirect effects of growth hormone? Well, this is actually the growth part. This is where it mediates growth via other hormones. So what happens is the growth hormone goes to the liver and produces these things called insulin-like growth factors. And those insulin-like growth factors are actually what stimulate the growth at the target tissues. Now, the major targets for growth hormone are going to be bone and skeletal muscle, but it is going to affect other tissues in the body. Those are just the major targets. How is growth hormone released? Well, this one's pretty easy. We have a turn on and a shut off button for it. So growth hormone releasing hormone, which is made by the hypothalamus, is going to bind to the anterior pituitary and stimulate the release of growth hormone. Growth hormone inhibiting hormone, also known as somatostatin, is going to be made by the hypothalamus, bind to the anterior pituitary, and inhibit the release of growth hormone. Also, a hormone called ghrelin, which is known as your hunger hormone, this will also stimulate the release of growth hormone. Imbalances of growth hormone, if you have too much growth hormone, a hypersecretion in childhood, then it ends up with gigantism. In adults, it will result in something called acromegaly. Hyposecretion in children results in pituitary dwarfism. And I have some pictures to follow here. So you can see gigantism on this slide as well as pituitary dwarfism. Now, something very interesting about these two brothers, they are actually identical twins, which means they should be identical, but they are not. As you can see, one had a pituitary tumor that caused a hypersecretion of growth hormone. So you can see, the gigantism in the brother on the left compared to the brother on the right. On this slide, it shows a progression of hypersecretion of growth hormone in acromegaly. So in an adult, you can see it almost looks like 4 different people, as the hypersecretion of growth hormone actually causes changes in the physical features. Another hormone made by the anterior pituitary is thyroid stimulating hormone, and it has another name. It's called thyrotropin. This one gets triggered by the release of a hypothalamic hormone called thyrotropin releasing hormone, and it gets shut off by a negative feedback mechanism. This slide gives the mechanism of release for the hormones and the cascade, as well as the negative feedback. So let's look at it. The hypothalamus releases a hormone called thyrotropin releasing hormone. That's going to bind to the anterior pituitary and cause the release of thyroid stimulating hormone, which is thyrotropin. That's going to go to the thyroid and cause the production of thyroid hormones. Well, when the thyroid hormones build up to sufficient levels, it's going to feed back. If you look at those dashed lines, it's going to cause a negative feedback that's going to shut off both the anterior pituitary and the hypothalamus, shutting down the entire cascade. If we didn't do this, what would happen? The thyroid hormones would raise too high. So we shut off the mechanism once we get within the normal ranges of thyroid hormone. ACTH, which is adrenocorticotropic hormone, is also known as corticotropin. Now, that kind of gives you the same type of thing we saw last time. So corticotropin releasing hormone from the hypothalamus is going to be the trigger of release for corticotropin, which is ACTH. However, we can also have other factors trigger it. So we can have this hypothalamic corticotropin releasing hormone causing the release of corticotropin in this natural daily rhythm, but also if we have stress factors such as things like fever, hypoglycemia, other stressors, these things can also trigger the release of corticotropin releasing hormone, starting this cascade. There are two hormones made by the anterior pituitary that are called gonadotropins. This is follicle stimulating hormone and luteinizing hormone. And we're going to talk about their function on the coming slides here. So we're going to get into more detail on the gonadotropins in chapter 27, the reproductive chapter, but to give you some stuff now, luteinizing hormone and follicle stimulating hormone are both going to cause maturation of the ovarian follicle. The luteinizing hormone has an additional effect of triggering ovulation, as well as promoting the synthesis and release of estrogens and progesterone. You're going to see that follicle stimulating hormone, I don't have it listed here, will also cause a release of estrogen as well from the follicle. In males, luteinizing hormone is going to cause cells in the testes called interstitial cells to produce testosterone, and follicle stimulating hormone is going to stimulate spermatogenesis. Again, we'll get into more details and kind of add to that picture in chapter 27. The release of gonadotropins are by gonadotropin releasing hormone, and the feedback for males, it's going to be a more direct negative feedback mechanism. For females, we have the hormonal cycle that, again, I won't get into until chapter 27. Prolactin is another hormone produced by the anterior pituitary, and its function is to stimulate milk production. A slight difference here in the control mechanism for the release of prolactin. It's primarily controlled by prolactin inhibiting hormone, also known as dopamine. And prolactin inhibiting hormone does exactly what it says, is inhibits the release of prolactin. So this is the main regulator because we generally don't need prolactin unless you need to make milk for breastfeeding. So what happens is, if you look on the second bullet point, blood levels of prolactin are going to rise towards the end of pregnancy, and suckling will also continue to stimulate prolactin release. So as long as you're breastfeeding, it will continue to cause the release of prolactin, which will continue the milk production. Now, if you had a hypersecretion, it would cause excessive lactation. It could lead to lack of the menstrual cycle, menses, infertility in females, and impotence in males. Thyroid is the largest endocrine gland. I'm assuming this is by weight because some glands may look larger. The liver does produce hormones, but it's not classified as an endocrine gland. It is your largest gland, but the thyroid is considered, at least according to our textbook, the largest endocrine gland. The two metabolic hormones that the thyroid makes are T3 and T4. T4 is also known as thyroxine. The T4 is tetra, which means 4 iodothyronine. That means 4 iodines. That's what the iodo is. And T3 is triiodothyronine. Now, a couple of details about these. They both bind to the same receptors. Okay. T3, however, is 10 times more biologically active than T4. However, and I don't have this listed on the slide, T4 is more abundant in the body, and you can convert T4 to T3 in peripheral tissues. Now, as we said in an earlier slide, that thyroid hormones, these T3 and 4 thyroid hormones, affect almost every cell in the body because every cell needs metabolism, and these are metabolic hormones. Thyroid hormones have a wide variety of effects. It is your major metabolic hormone. It affects metabolic rate, heat production, tissue growth and development, both skeletal nervous system as well as reproductive development. It also plays a role in maintaining blood pressure. These are just some general things you'll see from the effects of thyroid hormones. We've already covered the release and negative feedback of thyroid hormone because we talked about thyrotropin releasing hormone causing the release of TSH from the anterior pituitary, which is thyroid stimulating hormone, which goes to the thyroid and causes the thyroid levels to rise, or thyroid hormone levels to rise, When they rise high enough, it causes negative feedback. The imbalances for thyroid hormone, you have three that I want you to know for hyposecretion in adults. Myxedema is the most severe form of hypothyroidism. There's another called Hashimoto's thyroiditis. This is an autoimmune disease. It's actually the most common cause of hypothyroidism. And then endemic goiter. This is an enlargement of the thyroid due to a lack of iodine. Hyposecretion in infants, you've got cretinism. So dwarf stature and mental retardation are characteristics that you will see in cretinism. And this is generally when mom is deficient in thyroid during pregnancy. The infant ends up with cretinism. Hypersecretion is Graves' disease. It's the most common cause of hyperthyroidism. And it's characterized by two key things. It's characterized by a goiter, which is the enlarged thyroid, and exophthalmos, which is a bulging of the eyes. One thing to understand about the Graves' disease, it's a hyperthyroidism that causes the enlarged thyroid. Endemic goiter is a hypothyroidism that causes the enlarged thyroid. This gives you a picture of what goiter looks like. This is quite extreme. Here's an example of the bulging of the eyes with exophthalmos. And then this slide shows both. You've got on the left side, you've got the goiter, and on the right, you can see the bulging of the eyes with exophthalmos. Another hormone produced by the thyroid that is not a metabolic hormone is called calcitonin. An easy way to remember what calcitonin does is it puts calcium in the bone, which means it takes it out of the blood. So the job really of calcitonin is to lower blood calcium. It's an antagonist to the parathyroid hormone, which job is to raise blood calcium. So if you remember what osteoclasts do, they break down bone, and bone's primarily made up of calcium and phosphorus, right? That hydroxyapatite matrix. And if you inhibit the osteoclasts, then you essentially keep the calcium from going into the blood. So that's one of the things calcitonin does, and it also stimulates that uptake of calcium, like I said, into the bone. However, just keep something in mind as well. Calcitonin has a very minor effect in human physiology for regulation of blood calcium. Most of it is controlled by parathyroid hormone, which we'll talk about next. So the parathyroid glands are embedded in the posterior aspect of the thyroid, and there's usually 4 of them. The function of the parathyroid gland is to produce parathyroid hormone, and the function of that hormone is to increase calcium levels. In fact, parathyroid hormone is the most important hormone in calcium homeostasis because it will essentially raise calcium levels. Once calcium levels are within normal limits, then there's a negative feedback that shuts it down. Now, there are 3 mechanisms that parathyroid hormone uses to accomplish its one task of raising blood calcium. The first is it stimulates osteoclasts, which break down bone, and the matrix of bone is made up primarily of calcium and phosphorus, so that releases calcium into the blood, raising blood calcium. A second way is it enhances reabsorption of calcium. That happens in the kidneys. And then the third thing is it increases absorption of calcium in the small intestines indirectly through vitamin D, by activating vitamin D. The reabsorption, if you think about it this way, when you absorb something, it goes into the bloodstream. That happens in the intestines. Reabsorption goes back into the bloodstream, and that's happening in the kidneys. So all 3 of these mechanisms are going to increase blood calcium levels. Again, once levels are normal, negative feedback kicks in and shuts off the production of parathyroid hormone. For homeostatic imbalances of the parathyroid, you have hyperparathyroidism, which is usually due to a tumor. You're going to get softening of the bones and deformation. And if you think about that, if parathyroid hormone is going to increase blood calcium, what does it do to the bone? It's taking it from the bone. That was one of the mechanisms, right? So, but another side effect of that is the excessive calcium is going to depress the nervous system, can also do things like cause deposition of calcium in tissues and formation of kidney stones. Hypoparathyroidism, that's low production of parathyroid hormone. That can happen from trauma, removal of the glands, or even a dietary magnesium deficiency. That can result in tetany, respiratory paralysis, and lead to death. The adrenal glands are also known as suprarenal glands. Supra means above. The adrenal glands sit above the kidneys, renal. We think kidneys, we think renal, or when we hear the word renal, we think kidneys. And there's two parts of the adrenal gland. It's almost like two glands in one. We have the adrenal medulla, and then we have the adrenal cortex, and both parts are going to produce different hormones. The adrenal cortex is going to make corticosteroids, and it's broken up into 3 zones that produce 3 different classifications of steroid-based hormones or corticosteroids. Zona glomerulosa, this section produces mineralocorticoids, which we're primarily going to be talking about aldosterone. Zona fasciculata produces glucocorticoids, that's going to be focused on cortisol. And zona reticularis produces what are called gonadotropins, which are androgens, which are male hormones, which are produced for both males and females, but they're male hormones. A little mnemonic to help you remember the 3 zones is GFR, good for remembering. And that's going from the outside to the inside, or going deeper. This slide gives you the picture of the adrenal medulla and cortex, and then also the zones of the adrenal cortex. Something else I want to say about that is remember, and you'll probably hear me say this in other sections, when we hear the word cortex, a lot of times we think core is inside. Cortex is always going to be the outside or more superficial portion when we're talking about glands and organs. Okay, so aldosterone is the most important mineralocorticoid. And what it does is it causes the reabsorption of sodium. So if we go back to what I said before about reabsorption, absorption goes into the blood, reabsorption is going back into the blood, and that's happening in the kidneys. So what aldosterone does is it increases the reabsorption of sodium. So it prevents sodium losses, and sodium is essentially going from the tubules in the kidneys back into the blood, raising sodium levels. Another thing that happens with aldosterone, because sodium and potassium move in opposite directions, every time we reabsorb 1 sodium, we secrete or excrete 1 potassium. Now the 2 triggers of release for aldosterone, one of them is going to be decreased blood volume or decreased blood pressure. Now if you decrease blood volume, you will decrease blood pressure, but if blood pressure decreases independently of volume, it still either way is going to trigger aldosterone release, because water likes to follow sodium. So if we lose blood volume or pressure, then we want to put some more sodium into the blood, so water will follow, increasing that blood volume, increasing that blood pressure, because the more volume you have right in a container, right, the container of blood vessels, the more pressure you're going to have. So that's a trigger for release. That's number 1. Number 2, if you have rising blood levels of potassium, so high extracellular potassium, you got to get rid of it because it causes imbalance. Remember, potassium and sodium are important for muscle contraction and nerve conduction. So if you have rising levels of blood potassium, then we cause a secretion of aldosterone from the adrenal cortex so that we pull more sodium in, thereby excreting or secreting more potassium out and getting rid of it in the urine. A homeostatic imbalance of aldosterone is aldosteronism, which is a hypersecretion, and that's usually due to adrenal tumors. Now, if we think about what it does, so if aldosterone increases blood sodium, then what happens? Well, that means it's going to increase the water shift into the blood as well. So you're going to get things like hypertension, which is high blood pressure, edema, right, which is swelling and fluid accumulation in the interstitial space. Also, because aldosterone secretes potassium, you're going to get an excessive excretion of potassium, which is going to mess up or interfere with nerve conduction and muscle contraction. As far as our glucocorticoids, we have cortisol. Now, cortisol gets a bad rap because it's like this bad hormone, but cortisol in small amounts, in the proper amounts, with the proper cycles that our body uses cortisol, is very essential. It actually helps the body resist stress. It keeps the blood sugar levels constant. It maintains blood volume, helps prevent some water shift into tissues. Cortisol will also do things like provoke something called gluconeogenesis. Gluconeogenesis, we break that word down, glucose is glucose, neo means new, genesis means formation. So this is the formation of glucose from a non-carbohydrate source. It also causes a rise in blood glucose for those reasons, and as well as fatty acids and amino acids. Now the problem we run into with cortisol is the stress response. So under stress, it's going to trigger the release of corticotropin-releasing hormone from the hypothalamus, which we said before causes a cascade. The anterior pituitary binds the corticotropin-releasing hormone, releases corticotropin, which is ACTH. That is then going to get dumped into the bloodstream and then bind to the receptors on the adrenal cortex, causing the release of cortisol. Now, when we have enough cortisol, what normally will happen is, we will shut down that cascade. However, under a stress response, it will continue to trigger the release of CRH, which will continue that cascade, and then you get an excessive amount of cortisol, and some of the effects you get from that are, because it's anti-inflammatory, you're going to reduce inflammation, which is the first stage of repair. So if you do it excessively, it slows tissue repair. It's a catabolic hormone, so it's going to increase catabolism of proteins and cause some muscle wasting, suppression of the immune system, ulceration of the GI tract, and it can even cause failure of pancreatic beta cells. Now, the beta cells in the pancreas are the ones that secrete insulin, so when it causes those cells to fail, it can lead to type 2 diabetes. Again, this is if it's long-term. Homeostatic imbalances for glucocorticoids. We have Addison's disease, which is hyposecretion, and Cushing's, which is hypersecretion. Now, an easy memory cue for this is A comes before C, and hypo, which is low, comes before hyper, which is high. It's just a way to help you remember which one is the low production and which one is the high production. Now, Addison's is also going to involve aldosterone, so a deficiency in aldosterone as well as cortisol. And so that's going to cause a decrease in sodium levels, and then the decrease in, or the deficiency in cortisol is going to cause a decrease in glucose. Weight loss, severe dehydration, and low blood pressure called hypotension are some things that would be side effects of that or results of that. Hypersecretion, you've got Cushing's disease, very similar to what we saw with the chronic stress response, depressed cartilage and bone formation, slowing tissue repair because of the inhibition of inflammation, depressing immune system, cardiovascular, neural, and GI changes as well. Gonatocorticoids are sex hormones. Most of them are androgens, which I mentioned before are male sex hormones, and they can be converted into testosterone in the tissue cells or even converted to estrogen in females. They do contribute to a number of factors like secondary sex characteristics, sex drive in women, onset of puberty, estrogen production in postmenopausal women. However, generally the ovaries and male testes are going to have a more impact on those specific functions. If you have a hypersecretion of gonatocorticoids, you would have something called adrenogenital syndrome, which can cause masculinization. So what that would do is in females, it would give them some male sex characteristics. For males, you wouldn't really notice a big difference. If it occurred early, then it would look like basically early onset of puberty. But in males, because the testes produce so much testosterone, this wouldn't really have that much of an impact. So that takes care of the adrenal cortex. Now for the adrenal medulla. The adrenal medulla is going to produce epinephrine and norepinephrine. About 80% of it's going to be epinephrine, 20% norepinephrine. Now we'll also produce dopamine here, but we don't really deal with that in this chapter. The effects of epinephrine and norepinephrine are going to be what you studied in Anatomy 1, which was a fight or flight response. So things like vasoconstriction, which is constriction of the blood vessels, which is going to raise blood pressure, increased heart rate, increased blood glucose, blood is going to get shuttled more so to the brain, heart, and skeletal muscles due to the demand placed on them during this fight or flight response. Now, while epinephrine and norepinephrine work together, you're going to have more effective epinephrine on things like metabolic activities, bronchial dilation. The bronchioles are the small tubes in the lungs that opens them up, and then that diverting of blood more so to the skeletal muscles and heart. Norepinephrine is going to have more of a role in vasoconstriction, which, again, if you constrict the blood vessels systemically, that's going to affect the blood pressure and raise the blood pressure. A hypersecretion of the adrenal medulla hormones would result in, think about what a fight or flight response is and do it more so, right? So if it increases blood sugar, it's going to increase blood sugar too much. So you end up with hyperglycemia. It'll increase the metabolic rate. It'll increase the heart rate too much, maybe cause palpitations. It'll increase the blood pressure too much, cause nervousness, sweating, things like that. Hyposecretion would be something like an adrenal fatigue, and this is not life-threatening, but you just would end up with symptoms of fatigue. Now, the pineal gland is a small gland that you should have seen in the brain at the posterior aspect of the thalamic region, and it's actually part of the epithalamus. And what it does is it produces melatonin. And if you look down at the bottom, if we skip down to the bottom for a second of the slide, you see that we take an amino acid called tryptophan, we convert that, okay? Now just to be clear on this slide, those are arrows, not greater than signs. So we're converting tryptophan to 5-HTP, we're converting 5-HTP to serotonin, and then we're taking serotonin and converting that to melatonin. Now what does melatonin do? Has a role in sexual maturation and puberty, a number of physiological processes like body temperature, sleep, and appetite, works as an antioxidant as well as detoxifying certain molecules, and its most significant factor would be that second bullet point under melatonin's effects, would be the day-night cycles, which is basically the control of your circadian or circadian rhythm, and that's your day, your sleep-wake cycles. Now for the pancreas. It is both an exocrine, which is a ducted system, and an endocrine gland, which you said dumps its product into the bloodstream, the product being hormones. Most of the cells, 99% of all the cells in the pancreas, are these acinar cells, or sometimes they're called acini cells, and those are the exocrine portion of the pancreas that produce a number of juices or different juices that combine for the digestive system. We'll cover that in the digestive system. In this chapter, we're going to be talking about the pancreatic islets, also called the islets of Langerhans, which are the cells in the pancreas. It's only about 1% of the cells, and it's made up of alpha and beta cells. And the alpha cells are the ones that produce glucagon, and the beta cells are the ones that produce insulin. And insulin's job is to lower blood sugar. Glucagon's job is to raise blood sugar, if you remember that from the beginning of this chapter. Now, an easy way to remember this is just a memory cue now. Which one produces which? Well, alpha A comes before B, so alpha comes before beta, and then glucagon, G, comes before I. So you place them in alphabetical order, and you've got alpha cells producing glucagon, beta cells producing insulin. Again, that's just a little memory cue. So what's the role of glucagon? Well, really it only has one function, and that's to raise blood glucose levels, but it does it a couple of ways. One is glycogenolysis, think about glycogen, and lysis means to break. So to break the glycogen down. Glycogens are stored carbohydrate in the muscles and liver, and the target though for glucagon is going to be the liver. So it's going to cause the glycogen in the liver to break down. Glycogen is made up of complex glucose, so it's going to release that glucose into the bloodstream, raising blood glucose levels, right, which are blood sugar levels. Gluconeogenesis, we mentioned before, is making a glucose from a non-glucose source. Lactic acid would be a good example of that. Now, oftentimes I don't have you know blood levels, but I do want you to know the normal fasting blood levels of glucose, and that's 70 to 100 milligrams per deciliter. Now, while insulin's job is to lower blood sugar, it has a number of other effects as well. Okay, so when it does this, it will essentially put the sugar into either the muscles if the muscles are needing the sugar, or it'll put the sugar into the adipose tissue. The liver, kidney, brain, those organs don't need insulin to uptake the glucose. However, insulin will, again, if the muscles are full, let's say with glycogen, then it puts the glucose into the adipose tissue. Now, what else does it do? Well, it's going to inhibit the things that glucagon does, right? Because they're antagonists. So it's going to inhibit the glycogenolysis and the gluconeogenesis. It also has a role in participating in neuronal development, learning and memory, and it is an anabolic hormone, so it increases protein synthesis. On this slide, you can see the balance of blood sugar between glucagon, insulin, and keeping everything within that level of homeostasis. So what triggers the insulin release? Well, primarily it's glucose levels, right? We did mention that before, but if you have rising levels of amino acids or rising levels of fatty acids, that will also trigger an insulin release. Now, anything that's antagonistic to insulin would also cause an insulin release as well. So things like glucagon, epinephrine, growth hormone, glucocorticoids like cortisol, and even thyroxine, which is the thyroid hormone, those will all have an effect on blood sugar or raising the blood sugar, so that would trigger insulin to release to thereby balance it out, lowering the blood sugar. Earlier in the chapter, I mentioned the term diabetes mellitus. And if I ask you, is it type 1 or 2, the answer is yes, because diabetes mellitus is diabetes mellitus type 1 and diabetes mellitus type 2. What you have happening in type 1 is the beta cells of the pancreas are decreasing in their production of insulin until they don't produce insulin anymore. It is an autoimmune disease. I don't have that written on this slide, so go ahead and write that down, that type 1 diabetes mellitus is autoimmune. It's also genetic. Type 2 is a decreased activity of insulin or a decreased ability of insulin to bind to the receptors. When you see the term insulin dependent, we think type 1 diabetes because, again, you're not producing the insulin that you need. In type 2, it's mainly insulin resistant, and insulin resistance means an inability to bind to the receptors. So if the hormone can't bind to the receptor, then you can't have the effect of the hormone. Now, in type 2, you can have a decreased production as well as those beta cells begin to fail. So you might have decreased production of insulin as well, and they may need to take insulin as well as that diabetes type 2 progresses. So, some other things about diabetes mellitus. What's going to happen? Well, you're going to have glycosuria, which means what? You're going to have glucose that gets into the urine because the rising levels of glucose in the blood are going to spill over into the urine. And we'll talk more about how that works in the urinary system. Why are the blood levels rising? Well, insulin's job is to help shuttle the glucose into the cell. So if it's not doing that, where is it? It's staying in the bloodstream. Okay, and if you can't get it in the cell, you can't break the glucose down for energy, which in chapter 24 we'll talk about how we're going to do that. But you can't do it. So what you're going to do is use fatty acids for fuel. Now you all use fatty acids for fuel. But if you're primarily using fatty acids for fuel, what's going to happen is you're going to produce a number of ketone bodies, which it's a metabolite of fatty acid metabolism, and you're going to produce that regardless. But if you're only using fatty acids, a lot of ketones get produced. Ketones are acidic, so what happens is it winds up causing what we call ketoacidosis, which is shifting the blood pH below 7.35. Now, if you don't treat ketoacidosis, there are some severe symptoms you can see here at the bottom of the slide. Hyperpnea is an increased rapid rate of breathing, disrupted heart activity, and O2 transport. It depresses the nervous system and eventually can lead to coma and death. The three cardinal signs of diabetes mellitus are polyuria, polydipsia, and polyphagia. Polyuria is an increased urine output, a huge urine output. Polydipsia is excessive thirst. And polyphagia is excessive hunger. And now understand something about these signs. These are not diagnostic. However, if someone's experiencing all three, then tests should be done to see if there's some imbalances in blood sugar. Hyperinsulinism is what it sounds like. It's an excessive production of insulin. Well, if insulin lowers blood sugar, producing too much insulin does what? It lowers the blood sugar too much, so it causes hypoglycemia. And some results of hypoglycemia and that low blood glucose level is going to be anxiety, nervousness, unconsciousness, disorientation, and it can, if it gets low enough, lead to death. The treatment is just simply raising the blood sugar by sugar ingestion. Now we're going to get into just a tiny bit of male and female reproductive hormones, but I'm saving the majority of this information for chapter 27. So just some basics here. The ovaries for a female are going to produce estrogen and progesterone. Estrogen is going to be responsible for development of primary and secondary sex characteristics in females. Has lots of other effects that we're going to see again later on in chapter 27. Now the placenta, if pregnancy occurs, is also going to secrete some hormones as well, including estrogen, progesterone, and even HCG, which is human chorionic gonadotropin. And HCG is the pregnancy hormone, so it's the hormone that's used for the home pregnancy tests, or that's what it's looking for. It actually gets produced at about day 8 by the chorion of the embryo, and then later on by the placenta, but that is the pregnancy hormone. The testes produce a number of androgens, testosterone being one of the primary, or probably the primary one. And again, that's going to be responsible for primary and secondary sex characteristics in males, also normal sperm production and maintenance of the reproductive organs, as well as sex drive in men. The thymus is an endocrine gland, but it is also classified as a lymphatic tissue and is part of the immune system. The function for endocrine, or at least the connection, is it produces these hormones called thymopoietins and thymosins, and their job is specifically to cause T cell or T lymphocytes to mature. And I'll talk about what that means in the immune system chapter and how that works. Some other hormones, we have a few produced by adipose tissue. One of them is called leptin. Leptin is going to help you control your appetite. It actually stimulates energy expenditure while giving a feeling of fullness or satiation. So that's kind of a good hormone. An opposite to that would be the ghrelin that we mentioned before, way back when we were talking about growth hormone. Ghrelin actually conserves energy so you don't utilize or expend the energy or burn the energy, and actually makes you hungry. Resistin is another hormone produced by adipose tissue. This is an insulin antagonist. Another one called adiponectin will enhance sensitivity to insulin. I mentioned before insulin resistance. Insulin resistance is the inability to bind to the receptor. Insulin sensitivity is the opposite. It's the ability to bind well to the receptor. So the more insulin sensitivity you have, the better insulin binds to the receptors. The skin is going to produce vitamin D3, which is called cholecalciferol, which is actually, once activated, is an actual hormone as well. And I'll have a cascade on the vitamin D production in one of the chapters coming up. Some hormones in the GI tract. We've got gastrin that produces, this is in the stomach. Now there are endocrine cells in the stomach and the small intestines. The ones in the stomach produce gastrin. That's going to stimulate the release of HCl. Also, we have some enteroendocrine cells in the small intestines, and they're going to produce things like secretin and cholecystokinin. We'll talk more about those in the digestive chapter. Also serotonin as well. That's going to be in the stomach, produced as well by the enteroendocrine cells there, which actually contributes to gastric motility. These I'll really focus on more once we get to the digestive system. The heart's going to produce a hormone that we're going to see actually in a number of chapters called atrial natriuretic peptide. Now, atria is a chamber of the heart. This is where this is produced. Natri it means sodium, because basically your Latin word for sodium is natrum. So natrum is sodium. That's why it's Na on the periodic table. And so when we say natriuretic, it's talking about losses of sodium. So what this is going to do is it's going to decrease blood sodium concentrations by decreasing sodium reabsorption. Remember, reabsorption is going back into the blood. It's going to decrease sodium going back into the blood. If it doesn't go back into the blood, where does it stay? It stays in the tubules of the kidneys and leaves in urine. And that's going to have a large effect on blood pressure and blood volume because of water following sodium. We'll talk more about that a lot more in the future. Kidneys are going to produce a hormone called erythropoietin. Erythropoietin causes what's called erythropoiesis, which is the formation of erythrocytes, and erythrocytes are red blood cells. Renin is another hormone/enzyme, and that's going to stimulate a cascade called the renin-angiotensin aldosterone mechanism. That is something we go into detail on later in the heart chapters and urinary system as well. Some developmental aspects as far as hormones that will decline with age. We have testosterone, growth hormone, and thyroid hormone are all going to decline with age. You can add to that list estrogen for females. However, it's a very steep decline at menopause. PTH, which is parathyroid hormone, actually stays pretty constant. And this helps you understand why the risk for osteoporosis goes up significantly for females after menopause, because PTH, which is going to take calcium out of the bone, doesn't decline, whereas estrogen, which helps put calcium in the bone, it's very anabolic for females and also shuttles calcium into the bone for females, that is going to decline significantly at menopause. When we talk about anabolic hormones, we're talking about hormones that increase protein synthesis. The four primary anabolic hormones are going to be testosterone, growth hormone, IGF-1, which is insulin-like growth factor 1, which is produced by the liver in response to growth hormone, and then also insulin. So memorize your four. And then your primary catabolic hormone is going to be cortisol. So when we talk about maximizing your exercise hormone profile, we're talking about maximizing your hormone output. So basically increasing anabolic hormones and decreasing catabolic hormones. Of course, there's got to be a little bit of a balance there. So here's some things that have been proven in research to work. This is testable material, so make sure you memorize all 7 of these. One is using multi-joint movements, things like squats, hang cleans, power cleans, deadlifts, things that are going to use muscle groups across multiple joints. Number 2, working larger muscle groups, things like quadriceps, hamstrings, these large muscle groups. Both of these, you're using a larger mass of the muscle, which is going to require a larger output of hormones. Lifting heavy loads as well, that's going to recruit more muscle fibers, so for the same reason, it's going to increase hormone output. Decreasing rest between sets, they have found that is also, it's a little bit more depending on the time. It tends to increase growth hormone more than things like testosterone, although depending on what your set time is, testosterone can be increased by decreasing the rest between sets as well. Performing high-intensity interval training is another way. This one also really helps target growth hormone, but I think it has a pretty good effect on the overall hormone profile. Keeping workouts under 60 minutes, the reasoning for this is cortisol and testosterone spike throughout a workout. At about 60 minutes, testosterone starts to taper off and cortisol starts to spike. Now, this is not really practical for athletes because their workouts and their training sessions are much longer. If you can do split workouts, that helps. If not, you just need to mitigate, the effects of that excessive cortisol as best you can. Also, last but not least here is ingesting 60 grams of carbohydrates, ideally high glycemic carbs, I'll talk about that in a second, and 30 grams of protein within about 30 minutes of completing your workout or as soon as possible. There is an effect up to 2 hours, but it does tend to taper off. You can do just protein for individuals that are trying to stay leaner. They might not want to add that 60 grams of carbohydrate. If you do, though, it should be high glycemic carbs. This is the only time you really want high glycemic carbohydrates. That means it spikes your blood sugar. In other words, it gets the sugar into your system very fast. The reason we want to do that is because it gets sucked right into the muscle because there's a deficit in the muscle. So it's not getting put into the adipose tissue and there's not as large a spike in insulin. Like just drinking a soda while you're sitting there, things like that. A good source or a good form would be glucose polymers, which is just long strands of glucose. This is oftentimes what you see in the post-workout recovery drinks and things like that. Okay, so that wraps up the endocrine chapter. Make sure you download your PowerPoints and review through that as well as watching the video.